Chapter 6. Chapter 6 is our skilled nursing facilities payment system. In this chapter, we're going to learn about our payment systems, the patient-driven payment model, the variable per diem, and then also the value-based programs. So a skilled nursing facility would be a nursing home, example, healthcare facility that's licensed by the states. It does offer 24 hours per day skilled nursing care and also personal care services. It provides a skilled nursing facility on an inpatient basis, short-term skilled nursing care, rehab services to beneficiaries after an acute care inpatient hospitalization. Now, the patients in these facilities are called residents. So in this chapter, rather than saying patients, we will be talking about residents. So these are freestanding facilities for about 97%. They can be hospital-based. They can also be something called a swing bed. Swing beds are in small rural hospitals or critical access hospitals. They are used for both the inpatient and skilled nursing. Medicare does have to approve the dual use of these beds. Now, these beds don't swing. That's just a term that they use. And they are designated for both skilled nursing facility or inpatient, depending on how the patient is admitted into the system. Let me add here that Medicare Part A does pay for a skilled nursing facility. And the way that you are eligible, and it's important to know this, is that you are eligible for skilled nursing immediately after you have been in an acute care inpatient hospitalization of 3 days. And you can stay up to 100 days of covered service for a benefit period. So Medicare Part A pays immediately after an acute care inpatient of at least 3 days, and you can receive up to 100 days of skilled nursing facility services during a benefit period. Now, do remember that there are going to be some cost sharing for those beneficiaries. Now, some things that are some concepts, some pieces, some parts that go along with this skilled nursing. The first one there is an ADL. That's our activities of daily living. Residents initially are assessed to determine what they're able to do. This is our basic personal activities. That would be bathing, eating, dressing, mobility, transferring, the bed to chair, use of the toilet. These are used to measure a person's dependency or what they need assistance with. So in our facilities, we have 3 types of care. The first one is the personal care. That's custodial care, assistance with ADLs, self-administration of medicines, light housekeeping. They may prep meals. Anything that a person would typically do if they didn't have a disability. The next one is the rehab service there, and that's where we work to improve or restore function. Physical therapy, occupational therapy, speech therapy, or it could be a combination. And then the third type is our skilled nursing, and that's that daily nursing where it may combine the personal care, the rehab. They may have wounds with a dressing change. They may get injections, catheters, and that's usually provided by a nurse and a patient. Now, our skilled nursing is per diem, and it will cover the rehab, ancillary, capital cost, any other goods and services. It pays on average what would be expected for that nursing facility to efficiently deliver routine services. If it's something that's a high cost service, then it may be excluded and be paid in a separate rate. And we're going to talk about some of those things that do get paid more depending on the services. So here we are again. We have what's called the Patient-Driven Payment Model, PDPM. It was revised in 2019, and we kind of adopted a case mix. It is a per diem for that payment system. It assigns a resident to a payment category based on the individual resident characteristics. Now, the old system looked at total therapy and the resources. The old system was called the RUG, R-U-G, or Resource Utilization, and it's no longer used. With that system, it did thresholding, and they would provide just enough therapy to get to that higher reimbursement. So that's why they kind of changed it to make it more individualized. Now, there's several different ways that we can get the data needed for our PDPM, and they are listed there. We have the minimum data set, MDS. You probably heard about that since 1100. That's the type of data that we collect in our charting. We also have a care area assessment process. That's our initial assessment. And then we have the RAI utilization guidelines. All three of these look at the resident's functional status, their strengths, and their weaknesses to help us determine what category that individual patient needs to be put in for that per diem. So in looking at those components, there's 6. We have the nursing, the non-therapy, ancillary, the non-case mix, physical therapy, occupational therapy, speech language pathology. So adjustments are going to be based on the resident and the facility, and they're made at the component level. So let's go back. So each one of these is going to be adjusted based on the patient. Now, there's one that we do not adjust, and the one that's not adjusted is this one, the non-case mix. Oh, I can't get my little thing there. So the non-case mix is the only one that does not receive an adjustment. All the other 5 do receive an adjustment. So nursing, non-therapy, physical therapy, speech language, and OT all receive an adjustment. So our component's going to be adjusted, and then what we do is we assign a CMG. Now, a CMG is a case mix group, and that's a classification where we place those residents in similar groups. That's basically where we give them a functional score, looks at their comorbid conditions, their restorative nursing services. It doesn't look at time or the number of times per week. So we're just kind of putting them in that case mix group. And then we're going to assign a case mix index. Again, remember that 5 of those components get that case mix. There's one that does not. Know what a case mix group is, know which ones are assigned and which one is not assigned. We're going to look at each one of the components. So we're going to start with physical therapy and occupational therapy. Now, these are kind of assessed together. For each component, the resident's clinical reason and functional are used to determine that case mix group. And we combine those. And there are 16 possible case mix groups that they could be put in. The clinical reason would be like major joint replacement, spinal surgery, non-orthopedic surgery, acute neurologic, could be other orthopedic. And then for the medical management, it would be cardiac disease, acute infection, could be cancer, could be pulmonary conditions. So those are clinical reasons. Our functional is going to be based on section GG in our MDS3. So remember, that's our charting that we use in the skilled nursing. And that would be looking at toileting, hygiene, oral hygiene, sitting, standing, walking 10 feet, could be looking at walking 50 feet, whatever that patient is looking at. So let's look at table 6.1 in your textbook on page 120. And you're going to see where it's broken down under the clinical reasons on the left-hand side. So you can see there's 1, 2, 3, 4 groups for the clinical category of major joint replacement. Then there's 1, 2, 3, 4 for other orthopedics. 1, 2, 3, 4 other, I can't talk, y'all. 1, 2, 3, 4 medical management. 1, 2, 3, 4 non-orthopedic and acute neurologic. So for each one of those, let's say I have somebody that has a hip replacement. So I'm going to pick one of those top 4. Now, I have to have another piece of information in order to answer that question. So let's say that their MDS GG section is a 13. So I'm going to look, and that would be my third major joint replacement down. Now, you see it says range is 10 to 23, so I'm going to pick that. Now, if I'm picking the CMG, my CMG would be TC. My PT case mix is 1.88, and my OT case mix would be 1.69. So I'm just going to go across, and I'm going to pick those TC, 1.88, and 1.69. And that's how I'm assigning those CMGs. And each of the components gets a CMI. We add them all together at the end. So now what if I had somebody that had lung cancer? Remember I said to you that under medical management that would be cancer. So I'm going to go down to medical management. And let's say that their score, their function score is a 6. So that means that their CMJ group would be a TJ. I'm having a hard time talking today. TJ for lung cancer. And their case index PT would be 1.42. OT would be 1.45. So basically you find your clinical category, then your function, and then you move over. They would all fall in one of these areas for PT and OT. Now, one thing to note about PT and OT, they do have a variable day adjustment. So what they've found is that the cost isn't constant, and so it results in different per diem payments as the patient has been there. So what they have found is that the first 20 days cost more, and then it slowly decreases. And you can see that adjustment on table 6.2 at the bottom of page 120. But the first 20 days, they're going to be doing more with that patient. And then on day 21, it's going to start going down. And remember, they get 100 days. So as they stay, they're probably not going to be doing as much PT and OT on them. Next, we have speech language. So under speech language, we have 2 clinical categories. We have the acute neurologic, and then we have the non-neurologic. Under the non-neurologic, that would be like a joint replacement, acute infection, cancer, a cardiac condition. It could be where they have a swallowing disorder, cognitive impairment, they need a mechanically altered diet. You can see those listed on there. And then we look at comorbidity conditions as well as our clinical category. And there's 12 comorbidity conditions that increase the cost of care. And they are listed in table 6.3, and that's on page 121. So to assign the CMG and the CMI, that table is 6.4 on the bottom of page 121. This one is a little bit different because it's asking you like the number of conditions there, and then you have to answer if they have mechanically altered swallowing disorders. It has only one CMG for each row and only one CMI index. And again, it's going to get a number, that index, and then we're going to add it together. Our next component is our nursing. So in our nursing, we have 5 categories that help us come up with the CMG. Use of extensive services, clinical conditions, depression, number of restorative nursing services, and then our functional scores. So with these nursing, it kind of breaks it down into serious medical conditions and then conditions that require complex medical care. And there's kind of 2 levels in that medical condition. The first level would be like coma, sepsis, respiratory. Second would be radiation treatment and dialysis. Could be for medical care complex, could be like pneumonia, surgical wounds, and burns. If you look at table 6.5 on page 123 and over on 124, you're going to see that it's very similar to what we did with our other, and you will have some questions on your test where it will give you some scenarios, and you're going to have to determine which CMG or CMI you need. So let's say that I have a serious medical condition. I have depression, and my function score is a 9. What would my CMG be? So I have a serious medical condition that falls in class 1. I'm depressed. I have a 9. What would my CMG be? So on page 123, under serious medical conditions, I'm going to pick the third one. I have depression, yes. Then I'm a 9, which falls between 6 and 14. So that will make me an HBC2 for my CMG. Now let's say I have a severe burn, a condition that requires complex medical care, and my function score is a 16. So for that one, I would pick the 6th condition requiring complex medical care. It didn't say anything about me being depressed, so I'm going to say no. So in that case, I would be a CA1. My case mix index would be a 0.94. So the biggest thing with these is making sure you start in the right clinical condition and then answer the questions going across. With the nursing, you have to answer a yes or no to the depression. So again, make sure you understand that part so that you can answer those questions on your test. Now for the nursing component, if a patient has HIV and AIDS and they've been living with that for years, there is an adjustment to the account because of the extended nursing time. So there is an 18% increase for the weighted nursing staff time that is applied for an AIDS patient. So 18% increase is applied to the nursing component for an AIDS patient. So anytime there is a report of the ICD-10 code B20, they're going to adjust that 18%. Now, another thing that they do is they will add points to the NTA. And we're going to talk about NTA next. But they will also add 8 points to the NTA as well as adjusting that 18%. Now the NTA on our next slide here is our non-therapy ancillary component. And this is where we look at our drugs, labs, tests, respiratory therapy, medical supplies. We look at extensive services. We look at the comorbid conditions, and we use a point system. So with that point system, we assign points for services, and then those points are added up to give an NTA score. So for example, I just told you that B20 is awarded an 8 points for the AIDS. Another example, lung transplants get a 3 point, and endocarditis gets a 1 point. So those NTA points are totaled together, and it gives you an NTA score range so that you can get a CMG. That CMG is table 6.6. It's on page 124. And you can see in this case, we're just going to look at the score. It gives us our case mix group and then our case mix index. Now, our NTA is also variable. So with this, our costs are concentrated at the beginning of the stay. The adjustment is made for days 1 through 3. So remember that PT, OT has variable day, and now NTA also has. So we have two components that has variable days. With the PT, OT, it was 20 days. With the NTA, it's the first 3 days. And you can see table 6-7, that is on page 124 at the bottom. Now, our non-case mix component, remember that this is the one that we don't assign the case mix to. This is what represents our room and board services. It's a base rate. So it's not case mix adjusted. It's just a constant that is applied to every resident that comes in. So when we go to determine our PDPM reimbursement, each of those components is adjusted to account for our wage index. Remember that our wage index is looking at that geographic difference for the cost of labor, just like we did in Chapter 5. So everything has been adjusted. The 6 components are combined to determine the per diem. There are 2 levels of the base rates. There is an urban and a rural, and those are page 126, table 6.8. So for each of the components, there is an urban and a rural base payment. And these are decided for each year, and they're also going to be listed in the Federal Register. Now, remember that there can be multiple per diem rates for the resident stay because we do have some variable rates. So it's not always going to be that the person gets paid the same amount for every day that they're there. There are some variable days, so it is going to be different amounts for different dates. On page 125, figure 6.1 shows you the foundation, kind of how they do the multiplying, the adjustment, and all of that to come up with the rate for payment, to get the total payment. This slide shows you kind of in an easier format. First, you choose, are we going urban or rural? So we're choosing our base rate. Next, we take that geographic. Then we come up with our adjustment for our case mix, adjust for the day of stay, and we sum up the components. You kind of need to know these 5 steps: choosing your base rate, adjusting that wage index, getting your case mix, make any adjustments, and then total it up. Don't get hung up on the picture that's on page 125. Just kind of be able to talk through the steps. You're not going to have to total up on your test one of these. You just need to be able to talk through the steps. But do know that each one of those is a charge. Now, examples 6.1 and 6.2 do take you through the entire step of doing it. They are great examples, and you can go through and you can look at those. You'll see that it is kind of complex on how they pick those and do the calculations. You'll see that they've got different per diem rates for each day. Again, we're not going to be doing any of these on your test, but do go through and at least look at one to see the steps that are used to determine the total amount of payment. All right, let's look at the check your answers on page 128. So it says, what are the 3 therapy components used in the PD-PM model for SNF? So if we were to go back to our notes where we looked, as far as therapy, we had physical therapy, occupational therapy, and then we had speech language therapy. Number 2 says, describe the variable day adjustment for PT and OT. Remember that what they say is that initially we are having to spend more with them. So days 1 through 20, there's more reimbursement. And then day 21, after it starts to be adjusted and decreased. Number 3, what are the clinical categories available for the SLP component? So let's go back and look at the SLP. We have acute neurologic and non-neurologic. Those are the 2 clinical categories. Number 4 says list the 5 categories used to determine the nursing. That's use of extensive services, clinical conditions, depression, number of restorative nursing services, our functional score. That was on the slide, page 13. What services are included in the NTA? That's on slide 15. That's our ancillary and supplies, drugs, lab tests, respiratory therapy, and medical supplies. So I think that answers all of those. And then the last thing it talks about in our chapter is the SNF value-based purchasing program. Remember that this is where we connect quality measures to our payment system. Currently, we only have one measure, and it is that skilled nursing facility 30-day all-cause readmission after hospital measures. Basically, what this is saying is that we're looking at how often are the residents readmitted to acute care within 30 days from their original discharge date. Now, in 26, they are going to be adding some where they're looking at those healthcare-associated infections. They're going to be looking at the total nursing. And then in 27, they're actually going to be looking at patients being discharged from the actual nursing facility and readmits or death. So they're going to be looking at a couple of others. Our nursing facilities do get a total performance score. It looks at achievement and improvement. Remember that achievement compares them to nationwide facilities. Improvement is looking at how does it compare to their baseline? Do they get better? And then our skilled nursing facilities are ranked by performance, low to high. And then the higher ones are going to get a reimbursement or an incentive. So just like we talked about before with the VPF, there is a withhold of 2%, and this funds that incentive. So CMS redistributes 60% of the withhold to the high performing, and then the others don't get any. The skilled nursing facilities performance is reported on the Nursing Home Compare website. So you can go on there and you can actually compare nursing homes if you're looking for something like that for your family. And then lastly is our patient connection. And in this case, our patient had had their knee done and now they need to go to a skilled nursing facility. And with this one, again, it takes us through that entire procedure where you're actually assigning the CMGs and determining the cost. So you can go through and you can look at those and see again where those apply. Just read through those. The only thing that for your test you'll have to do is determine for maybe one component, a CMG or a case mix index. We are not going to be totaling up entire reimbursement amounts like these examples in here. There's 16 questions on the test. All right, so let's look our other little review PowerPoint. So we've got some just basic review. A lot of these are the same as what was in the slide we just did. Again, these are from the book where we're doing those major and you're having to go across. That's our PT and OT. 6.1, that is the one we were looking at that was on page 120. This one is on 120. These are on 121. And I like this. Let me go back. Very important that you look at the headings when you're deciding these classification groups. Table 6.5, this is on 123 and 124. Again, remember for age, we get an 18% increase, and then we also get points added to our NTA. Here's our NTA score. That is from page 124. There's our per diem for the NTA. That is on page 124. There's our urban and rural base rates. Those are on 126. And again, anything you need for the test is going to be on there. These are these steps. Make sure you can verbally talk through the steps. There's that foundation for adding everything up. And again, remember, you're not going to have to do that. That's on page 125. And then there's those examples where they take you through. And then this is your Patient Connect where it takes you through assigning those. So for practice, you might want to go through and just look and make sure you can pick those. And you can use that as a verification. All right, now let's look at our homework. I don't think the homework is too bad in this one. So we do have this grid. It says complete the attached grid. Brief explanation for each, not just a yes and no. Okay, so yes, this is a grid where you're going to come through. It's for chapter 6. You're just going to come in and you're going to put in the answers. Answer each one of these from your reading. Enter NA or none if it doesn't apply, and if it does, then fill out the answers. That's not too bad. Do that as you read. All right, and then here is a practice. What are we doing here? Skilled nursing exercise. So it says determine the CMG for the PDPM component discussed in each case. Use tables included in Chapter 6. So, PT and OT, the resident's clinical category is other, and the patient has a function score of 7. So, we are going to go to table on page 120. We're going to go to other orthopedics. Let me actually do this. Let me close this out. Let me open this up. Went too far. Okay, so it says that my resident is clinical category other orthopedic, and the patient has a function score of 7. So clinical category other, so I'm going to pick from one of these 4. My function score is a 7. It is asking me only what is my CMG. So what is my CMG for case 1, number 1? My answer would simply be TF. All right. Does everybody see how I got TF? So all 4 of these, it's asking me CMG. Now, part number 2 is asking me some questions about table 6.5 in my book. So I'm going to have to go to 6.5, and I'm simply going to answer the question. So all of this relates to our tables. Okay, let me close that. Is that all of our homework? Yeah, that's an easy one. Okay, that's all of our homework for this one. Good luck on chapter 6. This was a short and sweet chapter. Let me know if you have any questions.